Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. I hope you're doing well today. My name is Katie Berg, and I'm a research study coordinator with the Havey Institute. I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing today?
Doing just well.
Dr. Murphy is the executive director of the Havey Institute for Global Health, as well as the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics through today, November 2nd. As always, we invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with today's U.S. COVID statistics, the average new hospitalization per day is 2,312 people. Average COVID deaths per day is 91. And the new vaccine uptake, the 2023 COVID vaccine, has seen about 380,000 doses administered. Dr. Murphy, your reactions to those numbers?
Yeah, it's that's over a period of time, those vaccine doses, but the numbers are flat. They haven't really been getting bad, but to put it into some kind of perspective, there's still somewhere between 600 and 1,000 or so people dying from COVID every day. It's much more likely to die from this if you're 75 years of age or older. We knew age was a big predictor, and if you have these underlying medical conditions. But there's still a lot of people that are dying from COVID and ending up in the hospital. So last week, there were 16,000 people admitted to the hospital. Now, if you look a year ago, 2022, it was 23,000 per week. And if you look back into 2021, it was 44,000. So that was, when the numbers go that high, you really are stressing the hospital system. And of course, it's not evenly across the country. So some places are going to be worse than others, and they're going to max out their ICU beds or just their beds in general. So it's good that the numbers are down, but they have not gone away. Let's put it that way. COVID is still with us, and we have to learn how to live with it.
Yes, and I understand that kind of alongside the low vaccine uptake, there's been a new variant of concern rising. Can you tell us a little bit about that?
Yeah, so COVID continues to mutate. The new variant that's out there is called HV1. And it's basically taking over from EG5. And it's another Omicron. And it's doing this because it transmits even easier. So that's why something takes over, because it's easier to transmit. So slightly more transmissible, but it's acting the same. The Omicron family all kind of behaves the same so far. So it's now making up about 25% of the COVID cases, and this is from 1% last August. So we took August, September, October, 3 months later, it's 25% of all the cases. So the current new vaccine that's out there should help slow this thing down. So we really encourage everybody to take the new vaccine.
Absolutely. And kind of transitioning into our headlines for this week, there was an extremely interesting study this week released about the effects of COVID infection on male fertility. We've had a lot of questions previously about female fertility, and male fertility is often overlooked. So this is a really, really interesting study.
Yeah, this is an important little study because we've been focusing on women's reproductive potential and what happens in pregnancy. Everything has been focused in that particular area. And we know there are problems with COVID in women, but now this group is looking in men. It's a study of 132 participants, and they looked at COVID versus not getting COVID. And in the people that didn't get COVID had much higher sperm counts and better motility. The sperms are more active. And there's another measurement that they call DNA fragmentation index, DFI. And we know that that is associated, if you have that, it's associated with lower fertility. So the COVID group did much worse. It was significantly more of this DFI and sperm concentration down, motility down. So this is a relatively small study, 132, but it's important. And what needs to be done now that they know that there's this problem with COVID is what happens over time, how much of this returns to normal. And a lot of diseases and other conditions, the same kind of things can happen. And we have to see now if this gets better or not.
Yes, so very, striking data that came out of that study. We will, of course, keep looking into that topic for more news that is published.
Mhm.
But moving on, we had a kind of specific long COVID severity study, but it had some pretty shocking numbers. Could you delve into that for us?
Yeah, so this is about long COVID, and there's always this question about how much long COVID there is. So the way we've been looking at it in the United States for the most part, in many places, is like how many people come back in 3 and 6 months and have a condition that can be long COVID, which is hard to define anyway because it's so vague. And there's no real test for it. We've talked about cortisol and other hormones and stuff that we measure, but there's nothing really specific. So, and we have numbers like 7 to 14% people have long COVID. Now, this is a study from Denmark in 806 patients. And what they did is they proactively sent out a post-COVID symptom questionnaire. So to these 800 and some people. So, and then they looked and they found that, and this was repeated several times, and they found that over half, after up to 1.5 years, had failed to improve all their symptoms from COVID. So that's much higher than what we are reporting from the outpatient hospital databases that have been looked at. So, basically the harder you look, the more intensely that you look, the more you're going to find. And it just shows that this is much more common than we even were thinking it was.
Absolutely, very common and also happening on a global scale. So again, something we will continue to look into and report on.
Mm-hmm.
But moving on, throughout the entire pandemic and often around cold and flu season, there's a lot of talk about vitamin C and how it can, boost your immune system. This study or two studies that we looked at this week talked about intravenous vitamin C and the outcomes in patients hospitalized with COVID-19. Can you tell us about those findings?
Yeah, so vitamin C has been touted as a treatment for many different things, for cancer, all this stuff. And, all these big intensive studies have never really shown any benefit. So the same thing with COVID. So these two big studies, there were 2,590 people involved in these studies. So these are pretty big, and they're randomized to either get vitamin C or not. And if they're critically ill or not critically ill. And, some of them could have been in the ICU, and, they looked at everything. And basically they found nothing. It was absolutely no benefit. As a matter of fact, they had actually a slightly higher incidence of adverse, worsened outcomes. So, A, it doesn't work, and B, it could actually even make things worse. You're not supposed to be taking that much vitamin C just in general. You don't need it, and and it's just another study that shows some of these treatments that have been touted. You have to look at them and study them before you can discard them. But this is another one that goes into the wastebasket.
Yeah, And kind of a good transition, our final story for today is about remdesivir. And remdesivir throughout the pandemic has been studied in small studies and large studies. And this next one that came out is massive. Can you tell us about their results?
Yeah, so remdesivir was the first drug that was approved. It's an intravenously administered drug. And it got approved very early on in the pandemic. The drug was already out there being used for other things, and it turned out to have activity against COVID. So this is another very large study looking at 213,000 patients. And some of them very sick in the hospital, mostly people that are getting remdesivir are hospitalized because it's too hard to get, it's given intravenously. Although you can give that as an outpatient, but we already have pills that could do the same thing. So it's only really given to really sick patients. And they looked at these people and they looked at, how much oxygen they got. Were they on a ventilator? Did they get ECMO or any of these other kind of intense type oxygen therapies? And they found in the adjusted analysis that the remdesivir treatment had a statistically significant reduction in mortality, in death. And that was at day 14 and day 28 compared to the people that didn't get remdesivir. So it's just, we knew this worked. There was a suggestion that mortality was impacted, but based on all the studies from around the world, different populations and different groups at levels of sickness. So there was always this question, does this really make people live longer? And I think this is a pretty definitive study. The stuff works.
Absolutely. And that was a really great point that you made about, the level of severity of the sickness. You're not necessarily going to get an intravenous treatment or care as an outpatient. So it was important that the researchers here were looking at, the patients that were very, very sick and admitted to the hospital.
So it works.
Absolutely, which is great news. And on that note, we are going to wrap it up today. Thank you so much, Dr. Murphy, for your time and expertise. As always, we appreciate your reactions to the COVID numbers, as well as breaking down these headlines and studies for us. So thank you.
Thank you, Katie.
And thank you all for joining us again this week and watching the Ask Dr. Murphy series. If you have any questions, please feel free to submit them down below or to any of our socials listed in the description. Have a great day and stay warm out there.
Great.